Okay, welcome back. This is section 2 of the breastfeeding education. In this section, we're going to focus primarily on the practical help, positioning, and some of the other common situations. Let me share my screen and we'll move through the presentation. So the biggest piece of practical help you can give these parents is helping with the latch, obviously, which is positioning and making sure they get a good latch. The goal is really to get them independent. Our challenge is that they're here with us for such a short time. So we want to give them a little bit of help and give them some time to practice and hopefully at least get the breastfeeding parent somewhat confident with positioning before they leave. Do encourage them to do as much as possible. Again, emphasizing that skin to skin as much as possible. You can do a couple different tricks like trying to get a little bit of colostrum expressed to the nipple to get the baby interested in latching, demonstrating how to support the breast to get a deep latch, and then using pillows to support mom and baby wherever needed. I'm going to try to pull up this video here. This is a video from the Global Health Media. It's a nonprofit organization that puts together educational videos for worldwide use for low economic countries. And it's something that we've given money for so that we can use it in this education, but they do an excellent job of demonstrating how to attach a baby at the breast. We won't watch the whole video. We'll pull it up here. And I think this is another one that is available through the Get Well Network for parents to view in their room if you think it's helpful. So this is attaching a baby at the breast.
Attaching your baby at the breast. Breastfeeding is natural, and it's also a skill that can take some time and practice to learn. The key to successful breastfeeding is good attachment. If your baby is attached deeply to your breast, she will get more milk and breastfeeding will be more comfortable. This video will show how to deeply attach your baby and how to tell if she is attached well. There is a common misunderstanding that babies get milk by simply sucking on the nipple like a straw. If your baby is only attached to your nipple, she will get very little milk. But when she takes more of your breast in her mouth, your milk will come more easily. How you attach your baby to the breast is important for her ability to feed effectively and for you to make enough milk for her growing needs. A look inside the baby's mouth will show why. When the baby takes a big mouthful of breast, with the nipple pointed to the roof of the mouth, the nipple reaches a comfortable area deep in the baby's mouth. With the nipple deeper in his mouth, he is able to suckle more effectively, triggering the milk to flow. Good attachment is the key to breastfeeding success.
And here, pay attention to the
contrast,
chin and the
in
nose.
a shallow attachment, the nipple is centered in the baby's mouth, which is not wide open. The nipple lands under the hard roof of the mouth. As the baby sucks, the nipple gets pinched. This is painful and may injure the nipple. The baby is also unable to suck effectively and so cannot get much milk. What steps can you take to help your?
So we'll stop it there because I'm going to talk you through some positioning tips that you can help parents to get that deep latch. I was trying to speak over the video, but if you could tell with the good positioning, the chin was deep into the breast, not the nose. And with the second one, the poor positioning, the nose was going into the breast first. So I'm going to stand up and try and demonstrate for you some of the positions. This first image here shows you cradle and cross cradle hold, and some of the tips are outlined on the right. But let me switch screens here and I'll show you with a baby doll, just a demonstration of that. So What you'll find often when you walk into a room, most parents are going to cradle their baby in their arms like this. This is how most of us hold a baby, and this is how they'll start for breastfeeding. In this position, you can see that the baby is going to have to turn their head to make the connection with the breast. And once their head is turned, they can't swallow as easily. They need to be extended and comfortable in order to swallow well. So you want to turn the baby. The first thing you want to do is just turn the baby on their side. So the baby's tummy should be coming to mom's body. The next thing you'll probably see is a lot of people want to support the head. We've all been trained our entire lives, support the head, support the head. So you'll see a lot of handling of the head. Well, babies are cued up to touch. So if they're feeling all their touch back here, they're going to root backward looking for the breast there. So you want them to feel touch here at the front of the face. So to support the baby, it's better for the breastfeeding parent to take their palm along the shoulders here and just cradle behind the baby's neck. Usually the fingers will fall kind of around the ears. So she can just cradle here, wrap around the neck, and then the baby really fits nicely right along the forearm. Just kind of tuck the bottom right in the elbow, and then she can hug the baby up close to her. The bottom's going to kind of wrap around her body here. So tummy to tummy wrapped around. And then the important part is up front here. So if this were the nipple, you want mom's nipple to land right here in this little pocket, right between the nose and upper lip. And that way, when the baby opens wide, the baby can get a nice deep latch. So you want to have mom position the baby in the right direction so that the nipple is landing right at baby's nose. What you'll see a lot of parents do, again, they want to support the head. So they lift the baby way up high. Well, now the nipple's coming in down under the cheek and the baby has a hard time getting a connection. At the same time, if the baby's too low, same story. The other thing you'll see is if the baby's too far this way and the nipple's coming in at the forehead, the baby's going to have to reach to get their connection, have a shallow latch. If the baby's too far this way and the nipple's coming in under the chin, the baby has to bend down to get their latch. So again, have mom get comfortable in her chair or in her bed, wherever she's most comfortable, wherever her breast naturally rests and the nipple naturally falls, position baby there so that the nipple's hitting right at the upper lip and nose. Again, palm on the shoulders, cradle behind the neck, right along the forearm, high on the belly and close to the breast. She should hold her breast with a wide C hold. If she has her fingers down around the nipple, the baby can't connect well to the breast. So she has to widen her hold so that the baby can get a nice tight connection. A lot of parents are eager to get the latch, so you'll have a passive sleepy baby and a parent trying to force the nipple into the mouth. Mom should just sit still, hold the breast steady as a target, and wait for baby to open wide. Again, remembering that the first 24 hours of life, most of these babies are very sleepy. Many of them are disinterested in eating. So if they are at the breast, sound asleep, making no effort, you're not going to get a deep latch. You've got to wait for the baby to open wide and get interested. So that would be cross cradle. Once mom achieves a good latch, baby gets started and is going strong, she can bring her arm down under the baby and just rest and continue with the feeding. When you do that, what you're going to see next is she's going to want to, again, hike up on that head. So if she holds up too high on the head, that's going to roll the nose into the breast and close baby's nose off. So if she's looking really tense here, kind of stroke her to soften her shoulder, soften her arm. And usually if she's got the baby connected, if she just lets her arm naturally fall, it's a perfect place for the baby to rest. So that would be cross cradle. From there, she's got this hand free now to compress the breast if she needs to rub the baby's hand, tickle the baby's feet, whatever she needs to do to keep the baby active during the feeding. This is cross cradle hold. This is cradle hold. You can also do football hold, which is going to look just about the same, except mom's going to turn her body and bring her baby to the side. So football, common mistakes with that. Our parents start with the baby way out too far from the breast. Baby comes up high on the breast and bends down. The key to football hold, again, palm on the shoulders, cradle behind the neck. Bring the baby low and back far enough so that the nipple is landing right at that upper lip and nose area. Baby's still on their side with their belly coming to the body. The trick with football hold is usually these parents are in a bed and you can see if the baby's too long, the baby's going to start pushing off the bed and get too far away from the breast. So this tends to be a good position for a lady with a very large breast. So there's lots of room to position the baby. An average size parent, you know, the baby's going to tuck back and be pushing off the bed and it'll make it challenging. So normally the cross cradle hold is one of the best positions to start with babies here. So those are positioning techniques. Let me get back to our slide here. Again, just pointers to show you in still shot. On the left here is the cradle hold, obviously an older baby. On the right here is the cross cradle. There is also here, we've got football hold on the right. There's side lying. I didn't demonstrate that for you. This can be a really excellent position for any mom who has perineal pain from delivery and wants to get off her bottom for her feeding. She can just lie on her hip in her bed, flatten the bed, lie her on her side like she's sleeping on her side. Baby's also on their side. Still the same basic rules apply. Tummy to tummy, nose to nipple. Really, in any position, those are going to be your basic rules. The baby's tummy should be in touch with mom's body, and the nipple should be landing right in that pocket of that upper lip and nose area. Again, remember our counseling skills suggest position changes, don't demand that she do it any one way. This is all about helping her find her confidence and helping her baby be comfortable enough to latch well. This is again just some still shots. This shows nicely, this is a rather large areola, and you can see the nipple here pointing in at the top, going for the roof of the mouth. Once the baby opens wide enough and gets on, you have what's called an asymmetrical latch. So you see more of the areola up above by the nose area than you do down by the chin. The baby's going to get a deep latch that way. This is again a reminder, most parents grab hold right down by the nipple, trying to force the nipple in the baby's mouth. With that positioning, the baby can't achieve a deep latch because they're going to land on the fingers. So mom needs to widen her hand and just a big C hold on the breast. There's not a lot of shaping, pinching, pushing that has to happen. If the tissue is stretchy enough, she just has to support the breast as a steady target to help draw baby in. This is again a nice still shot of that asymmetrical latch. You see the areola disappears down here in the chin. It's very visible up here by the nose. And this looks like a nice wide gape. Lips are flanged, so beautiful latch. I'll try to pull this video up as well. This is a video from Dr. Jack Newman. He's a pediatrician out of Toronto.
Have something better, right?
Who runs a breastfeeding clinic, and he'll just show you again a quick demonstration of a good latch here.
Okay, so this is the positioning that we teach. Again, it's important to realize that babies don't always have to latch on this way, but this makes it more efficient and the baby gets more milk. So we ask the mother to push in here, hand underneath the baby's face. The nipple then runs along the baby's upper lip just to tickle. Wait for that gape. Maybe on TV you have to do that's right, and then straight on. There. So the baby's chin is in the breast, but not her nose. And she covers more of the areola with her lower lip than her upper lip. And that little pause in the chin, there is a mouthful of milk. Sometimes you can pull the chin down. It's not on as quite as well as she should be. And that's even more like that. There, mouthful. Each pause is a mouthful. And you can see that on day one, that pause, if the baby's latched on properly. It's no big deal now because the mother has a lot of milk. But that baby is getting milk and drinking well. And a baby who's doing what she's doing there for 20 minutes won't even take the second side. And if she nibbles for 20 hours, she'll come off the breast hungry.
So again, that's Dr. Jack Newman. He's a pediatrician out of Toronto who runs a breastfeeding clinic there. He has some really excellent videos on his website. A lot of them are very short, only 30 seconds or so, and they are listed in our new parent packet that they get in their admission folder, so they can reference those when they go home. They are not loaded on our Get Well network. So how do we address concerns, common concerns about milk supply? I think most of you have heard parents say, I don't have any milk, or is my baby getting enough? My milk's not in yet. This idea of a perceived milk insufficiency is very, very common for new breastfeeding parents. And I think it's so common because, again, the images we see are babies who are a little older, moms who are breastfeeding once their milk has come in. We don't often see images from the first 24 hours of life. So babies are born with a very small stomach capacity. Moms are making a very small milk volume for that reason. The milk they're making is called colostrum. It's very concentrated with all the nutrients and immunities that the baby needs. but because it's such a small volume, it's common for these parents to think that they don't have enough milk. So we'll talk about behavioral signs to help parents determine what their baby's getting at the breast. They will never know exactly how much their baby's getting at the breast, but behavioral cues can really help them understand that. And then helping them realize that if the baby's not getting enough, it's not often due to a truly low milk supply. It's due to a baby who is not skilled at breastfeeding yet. So it's the baby's technique with a poor latch or an ineffective suck that's not removing enough milk. So we have to have that conversation with parents as well. So how do you know if the baby's getting enough at the breast? Signs of effective sucking, just like the Dr. Jack Newman video showed, you want to see slow, deep sucks at the breast. You want to see a pause between those bursts. Cheeks should be nice and round. You don't want to see any dimpling of the cheek. If the baby's dimpling, you know that they're sucking in on their cheek or sucking on their tongue. And the breast, you should see visible breast movement. Up where the baby's nose lands at the breast, you should see that breast tissue being tugged every time the baby takes a suck. If you just see the baby bouncing on the breast, no breast movement at all, you can feel assured that the baby doesn't have a good connection. And then the biggest sign, I think, at the end of a good, effective feeding, the baby should look really relaxed. Normally when babies are hungry, they have tight fists, they're active up at the mouth, they're rooting. And then if they breastfeed well, their arms relax, their hands open up, and they look very content at the end of a feeding. If they've been at the breast for 10, 15, 20 minutes and they come off still looking just ravenous, you know they didn't get enough at the breast. Signs of ineffective suckling at the breast, if they're taking really quick, short, choppy sucks, no long pulls happening, that wouldn't be a very good latch or a very good sucking technique. If you don't see the breast pulling, if you hear smacking sounds, you know, there's not a good seal at the breast, so you don't want to hear any of those sounds at the breast. Again, the dimpling and then showing hunger cues. So kind of the opposite of the signs of the effective suckling. So watch for those when you're assessing a feeding with your families. How can labor impact breastfeeding? IV fluid, a lot of our families are here for inductions or cesarean deliveries. They receive IV fluid through their labor and delivery, and that can lead to edema and especially breast edema. So if the breast is edematous from their IV fluid or from their delivery, it makes the breast tissue really tight and taut, and it can be difficult for the baby to achieve a latch with that. We have something in every stack room called breast shells. They look like this. I'll switch screens so that you can see a little better. So these are the breast shells. These are stored in every clean stock room. And when you open the box, I just want you to see that you'll have two different options. Hopefully you can see those there. You've got this one with the smaller ring here, and you've got this one with the larger ring. This is not dependent on breast size or nipple size. This is dependent on your indication for use. So in a case of breast edema, sometimes the breast is so edematous that the nipple actually flattens or inverts. In that case, you'd want to use the smaller ring. So the idea is that mom would center this on her nipple. She puts her bra on, and when it pushes on, it's going to push some of that edema back and help invert the nipple. The design, it has holes here. The holes would go at the top. It's a cup design so that if she drips any colostrum, it'll catch the colostrum there. The important thing to know is this little edge here is kind of sharp. And if she wears this for too long, it's going to cut into her skin and be painful. So you want to just have her wear this, 5-10 minutes before a latch attempt. She would need a bra on to apply the pressure to push against the breast. So this is called a breast shell, and that can be helpful to help avert that nipple if it's due to edema from IV fluid. Long labors, long inductions, again, those are fairly common on our unit. So you'll see parents and babies that are just exhausted after that. Babies can be kind of disorganized after that as well. Again, you want to encourage them to attempt breastfeeding every few hours, really focus on your skin to skin. They're both resting and recovering. And then if the baby's just not ready to do it yet, you can set mom up to start pumping. She should pump both sides for 15 minutes, at least every 3 hours, to help stimulate her milk production. And then a cesarean delivery, some parents are worried that that will interfere with their breastfeeding success. It can include any of the challenges that we've already talked about, but usually what we see is most of these delivering parents are just apprehensive about positioning due to their incision. Typically that cross cradle hold, you're getting the baby high enough on the belly, far enough away from the incision that it's not usually too difficult for these families. You can consider football if she is still too painful with that cross cradle position. I would not do side lying until she has time to heal a little bit. It's just going to be too difficult for her to position back and forth for the sideline. One thing to keep in mind with the babies born by C-section, again, because of the IV fluid, a lot of times you'll see a higher weight loss in those babies. So we have guidelines for determining weight loss if it's problematic or not, but just know that sometimes they arrive kind of fluid overloaded from the IV fluid. Their first weight is maybe artificially high. We do another weight check, they've lost some of that fluid, so their weight loss appears high. As long as they're making adequate diapers, appearing content, feeding within expectations, we wouldn't consider the weight loss too problematic. We will keep an eye on it though. When would breastfeeding be contraindicated? So for the breastfeeding parent in the United States, if she has an HIV infection, we would say she should not breastfeed. In other parts of the world where HIV is more prevalent, they would support breastfeeding. But here in the United States, we would say no to an HIV infection. We would not want that parent breastfeeding. Active or untreated tuberculosis, active herpetic lesions on the breast. And just take note that if there's an unaffected breast, a breast with no lesions, the baby could safely breastfeed from that breast. Varicella, considered to be infectious to the infant, and the human T-cell leukemia virus type 1 or 2. Those would be contraindications for the breastfeeding parent to breastfeed. For the infant, it's very rare. It would be galactosemia. That's something that will be detected by the newborn screen. So we probably won't know about that here in our population, and pediatricians would get involved. So that would be a contraindication for infants. As far as medications, again, many people are quick to disqualify themselves from breastfeeding. In general, most medications tend to be safe for breastfeeding. There are a few exceptions. Cytotoxic chemotherapy, we would say no to breastfeeding for that. Radioactive iodine, no to breastfeeding, but note that iodine-based contrast agent is safe. So if someone's going down for a CT scan, we would consider it safe to breastfeed. She would not have to pump and dump for that procedure. Any breastfeeding parent using illicit drugs, for example, cocaine or heroin, if that parent has had a positive drug screen within the last 30 days, we would recommend formula feeding, not breastfeeding. But do keep in mind the baby's pediatrician is often the one making the determination on breastfeeding for these cases. They do have an algorithm they follow, and they'll decide case by case if the baby should be breastfeeding or not. Marijuana is a common question we get. Technically, marijuana is contraindicated for breastfeeding, but it's a difficult conversation because we don't know, how often or how frequently they're using it, what the indication. If we meet someone who's using medical marijuana on a daily, regular basis, we would consider that contraindicated, and we would recommend not breastfeeding. They're here with us for such a short stay, a 24 to 48 hour stay. If they're initiating breastfeeding as lactation consultants, we will go in and support effective breastfeeding techniques, but we will share with them the education on marijuana and encourage them to make a choice to breastfeed instead of using marijuana. And again, we would involve pediatricians because they will be caring for the patient long-term, and they'll have those conversations to decide if the baby should continue breastfeeding or not. Challenges, you'll have challenges for the infant and for the breastfeeding parent. In the infant, tight frenulum can be a challenge. I don't know if you've all seen one. If you haven't, you can Google images of that. There's an image here, this baby's mouth. That's a pretty significant tight frenulum. Here at Michigan Medicine, if we notice that as lactation consultants, we'll usually notify the pediatric team, and they will determine if they need to consult with ENT, ear, nose, and throat. And then they will come up to the bedside and do an assessment. And oftentimes, if it needs to be revised, they'll do that right at the bedside with the parents right in the room. Sometimes they don't need to be revised. Sometimes the tongue can stretch out well enough. If it can stretch over the gum line and make a comfortable cushion between the gum and mom's nipple, and the baby's functional with it, then they would not revise at all. But that's what a tight frenulum or a tongue tie looks like. Tongue thrusting can be another challenge for babies. A lot of babies arrive with just kind of a wild tongue that's darting every which way. And if it's tongue thrusting or pushing forward, it's going to push the nipple out of the mouth. And then sleepy infant, that's almost every baby we're working with in the first 24 hours of life for sure, usually the first 2 to 3 days of life. For the breastfeeding parent, these are challenges, but they're not contraindications to breastfeeding. So a challenge could be a very large breast. It may be hard for mom to visualize her nipple or to support her breast. We can do like a towel roll or a blanket roll to help lift the breast if needed. Flat or inverted nipples, they can be a challenge. Again, not a problem necessarily, but always remember that babies breastfeed, they don't nipple feed. So as long as the baby is active, alert, opening wide, getting on the breast and drawing that breast forward, they should be able to draw that nipple forward. Risks for low milk supply, we'll talk about in a little bit, and painful nipples, again, we'll talk about expectations for that. So for flat or inverted nipples, if you encounter a mom, we talked about the breast shell. A lot of times you'll meet a mom who looks to have a very flat or inverted nipple. It's important to ask her if her nipple normally presents that way. If she arrived with a normal invert nipple and then ended up flat or inverted through her delivery, we know it's due to IV fluid or edema. So in that case, we would promote the breast shell again, just the one with the little ring here. And then another option, some people will consider using a hand pump. So if the mom is someone who arrived and normally has flat or inverted nipples, she could use the manual pump to help invert that forward. So if it's her normal presentation, it's usually adhesions that are holding that nipple back. And a little bit of activity with a hand pump can help loosen those adhesions and help invert the nipple. The breast shell is designed more to push the edema back and help invert the nipple that way. So just know if she's doing this because she's got edema, just know that that manual pump may actually have the reverse effect because it may pull more edema forward and further flatten that nipple or further invert that nipple. So breast shell for edema, manual pump for if it's her true presentation, flat or inverted nipple. Risks for low milk supply. We don't have to talk about every one of these, but there is a long list of risks for low milk supply. Most of them are hormonally based, surgically based, maybe, infertility is a very big issue. So I think an important simple question you can ask families is, did you have breast change during your pregnancy? Have you noticed colostrum dripping from the nipple? If she had positive breast change and notices colostrum, it's pretty promising that she'll make an adequate milk supply. But if she has a long list of risk factors, or if she was an infertility case, if her body was challenged to get pregnant or make a baby, it may also be challenged to make milk. So that's probably the most important one to hone in on and get that family pumping as soon as possible. Again, you don't have to remember all the others. We're not going to really see evidence of her milk coming in during her stay with us unless she's a long-term stay. So just setting her up with good understanding of supply and demand, expectations that milk should come in between day 3 and 5. And if she gets all the way to day 5 and hasn't seen something, we would want her to follow up with the outpatient clinic to determine a plan. We do get a lot of questions on herbal supplements. What can I take to help increase my supply? There is really little or no scientific evidence to support any of the herbal supplements. So we don't recommend herbals. In some cases, they do have risks involved. So what we talk is straight supply and demand. So if the baby's not doing their job with good latching and good milk removal, we want mom backing that up with pumping. So focus on the pumping if you have any concern for low milk supply. Nipple pain, again, knowing what's normal and what's abnormal. This is new for most of these parents. It's a lot of moisture, it's a lot of friction. So to expect like a chapped tenderness to the nipple would be completely within normal. We expect that. And to treat that, we give every parent a tube of lanolin. So lanolin is safe for the babies. Lanolin can be applied after breastfeeding or after pumping and doesn't have to be removed before a feeding attempt. Keep in mind that some people do not like lanolin. If they have a wool sensitivity, they may have a sensitivity to lanolin. So there are a lot of other nipple balms, nipple products on the market. As long as they've been produced by one of the breastfeeding companies, Medela, Amida, Spectra, they're usually going to be safe. And a lot of your families will come in with their own nipple balm. The best thing for nipple pain, obviously, would be express breast milk or colostrum. So if she can hand express a little bit of colostrum and rub that into the nipple, that's going to be the best thing for nipple pain. What would be considered abnormal is any damage to the breast. So you really should not see bleeding, bruising, blisters, cracking. Any of that would be considered abnormal, and it indicates a bad latch from the baby, or bad positioning. So we want to get involved to correct that. So know that those things are not normal. So many parents will just endure that kind of pain, and they'll tell you, at least the baby's latched, I can take it. Well, just know that it's not normal. Just a normal tender, chapped feeling is all we would expect. So again, for comfort measures, start with express colostrum. That would be the best. Lanolin would be your next solution. I'll switch over and show you something else that we have is these are called comfort gels. These are produced by Amida. They're basically a hydrogel. And what they look like, they come in a pack like this. You get a set of 2. And if you just open this up, it's just a little gel pad. And it's moist wound healing, basically. So she would wear these inside the bra. She can cool them in the refrigerator first, rinse and reuse these for up to a week. These are not stocked in the clean room. These are stocked in the lactation office. So you do have to get a set of these from a lactation consultant. And we try to just give her one set and encourage her to rinse and reuse for a week. They do sell these at most of the drugstore and baby supply stores, so she can get some additional. But usually once the milk has come in, they get kind of slippery and sloppy anyway. So just for the initial, damage that we maybe missed, a lot of times that first feeding at delivery, again, there's so much going on. Baby may get a bad latch right out of the gate and cause some damage that someone wasn't aware of. So those would be hydrogels. We're going to stop session 2 here and we'll move on. Our next section is going to be on pumping and supplementing. That'll be section 3. So I will see you there in just a bit. Thanks.